Welcome to A Journey to Whole Woman Health, the podcast where science, mental health, and faith come together to educate, empower, and encourage women in every season of life. We are your hosts, Dr. Jamie Erwin, board-certified OB-GYN,
and Dr. Mary Kathryn Nader, licensed professional counselor with a PhD in counselor education and supervision. Jamie and I have been friends for over 30 years.
Each week, we explore the intersection of body, mind, and soul, bringing you evidence-based medicine, meaningful conversations about mental health, and stories that remind us we're not alone on the journey.
So take a deep breath, settle in, and let's begin the journey.
1 in 3 women will experience pelvic floor dysfunction during their lifetime, yet most women have no idea what the pelvic floor even is. If you've ever peed a little bit when you've gone running, avoided jumping exercises, experienced painful sex, or felt pressure down there, today's episode may answer questions you've been wondering about for years. We have today our guest in studio, Dr. Haley Miller, a doctor of physical therapy and pelvic floor specialist who is passionate about helping women restore confidence, strength, and quality of life through evidence-based pelvic health care. Dr. Miller works with women across every stage of life, from pregnancy and postpartum to athletes, to perimenopausal and menopausal women, and those struggling with issues like pelvic pain, urinary leakage, painful sex, and beyond. So we're so delighted that Dr. Miller is here. She empowers women. She educates women. She is just all the things that A Journey to Whole Woman Health is about. And we can't wait for her to share all of her expertise. Welcome, Dr. Miller, to the podcast.
Thank you, guys. Yes. I'm excited to be here.
We're glad you're here. Yeah. Thank you for making time to come. Course. Yes. So let's get started. Let's start with just what is the pelvic floor? Like, what is it?
It's a collection of things, but usually when we talk about the pelvic floor, we refer to the structures within the bowl of the pelvis. Should have brought my pelvis model. That would have been helpful. But it's a group of connective tissue, ligaments, tendons, and muscles that help support and control bowel, bladder, and sexual health and function. It does a lot for us. It also helps manage pressure in our abdomen. It carries a lot of weight above. And so I guess when I talk to my patients who have come in for physical therapy and have like pelvic health issues and they're not really sure what to do, we start with educating on like what the function is of the pelvic floor. So it's like everything: pee, poop, sex, support, and stability. So if things down there are not feeling right, that's when we want to go to pelvic floor therapy.
Okay. Yeah. So give us some examples of when would things not be going right? Like what would people notice to say, oh, maybe I should consider this?
Okay. So usually, we'll start with our bowels because everybody has to poop, and hopefully we're pooping every day. So bowel movements are really important to monitor. So ideally we should be pooping every day. It should be strain-free, soft formed. And kids are constipated. Sure. And sometimes I'll see infants and kids and like teenagers who are struggling with bowel movements. In adults, we have conditions like IBS. Definitely go see a pelvic floor therapist for that.
Really?
Because there's a lot of things that we can do to help support regularity, to support the tension, the pain that is produced from being uncomfortable from diarrhea, constipation. Typically, like we see them medicated with like medications like Linzess and other things, or they're on Miralax for a lot of constipation, and we want to get them off of that ideally. So we are working on coordination, abdominal mobility, visceral mobility, everything that's related to the abdomen and pelvic floor. So constipation, diarrhea, hemorrhoids even, fissures. Like there's some things that we can do to help manage pressure in that area so they're not as intense or prevalent, or they don't experience pain and itching and that kind of stuff. Let's see, anything like a rectal pain. Usually we have patients come in and they'll complain of like rectal spasms, and it could be completely random and unexpected. Alongside the bowel area and rectal area, we do see a lot of patients who have like tailbone pain. So they can't sit very long. That could be from an injury from childhood or birth, labor, that kind of stuff. Bladder health. So we have, things like leakage, incontinence. That's never normal. And that there's a lot of little things that we can do to help get rid of leakage completely, even in pregnancy. Like there's little tips and tricks that we can do to teach them coordination and breathing and pressure management. And it's not just like Kegels. So we're not just teaching how to contract those muscles down there. And then bladder conditions like urgency, frequency, pain. Like if you have patients who are or people who are having discomfort with urination, like there's just this sharp stabbing pain when I pee, but it's not a UTI, we can help with that. And then I'm trying to think what else. UTI type symptoms, anything where there's burning, pressure, aching pain down the thighs or in the abdomen.
Yeah.
And then sexual health. So we can do a lot for that department. And not only sexual, but also menstrual health. So if we have pain with penetration of anything, tampons or speculums or during sexual activity, we can help get rid of a lot of that pain. And a lot of it is coming from the brain. So we work a lot alongside a lot of sex therapists, mental health therapists, and then OBs who help us prescribe the right medication or topical products. Sexual health stuff, we can work on prepping for sexual activity. If they have never had sex, we can kind of teach them what may come from it. And we work on stretching, mobility, and then we can educate them on their pelvic health, what the pelvis is, what the organs are, the structures, what they're responsible for. And the sex education that we typically miss from young adulthood, we can do too. Gosh, there's so much. I feel like I'm missing a ton, but that's bowel, bladder, and sexual health and menstrual health are the main components of pelvic health therapy. And beyond that, there's so much more. So yeah.
That's great. Okay, so when somebody says, okay, I want to work on this issue, then they call and make an appointment. What will would they expect in that first appointment? They're probably like, oh my gosh, what's going to happen?
Usually a lot of people are nervous and anxious because they think it's a vulnerable area.
It's a vulnerable area
and
that
we don't know.
They don't talk about very much, that maybe their OB has seen, but nobody else.
Yeah, they're only my OB and my doctor or my partner knows about this area. So typically the first visit is just getting to know the person, tell me more about what's going on. I always will explain what the pelvis is and the pelvic floor anatomy and the function of everything. But the most important thing that I explain is we don't have to ever do an internal exam unless you want to. And there's so many other things we can do externally to treat the problem. And then as you get more comfortable with me and we address all these other things, and we can talk about pelvic floor exams. So first time visits is just talking about your aches and pains,
fully
head to toe.
Clothed. Let's just sit
fully
down and
clothed,
chat.
like this. We're just talking to each other now. After that is a physical exam. Let's see how your hips move. Let's see how you move with a squat. Let's see how you're breathing. Let's see how tight your muscles are. So we'll kind of check mobility of the legs and the glutes and the abdomen and the rib cage to see how well things are moving.
And that's just by doing some exercises?
Yeah, exercises, hands-on assessments, having them do a little stretching, some breathing seated or laying down. With the most common is leakage. They're just experiencing leakage with running or laughing or coughing. So we do a lot of assessments in standing when they do experience those issues. So we'll do standing assessments. Let's see how you're coughing. So we'll make them do fake coughs or fake sneezes, and we'll check pressure in their belly, see what their belly's doing, see what their posture is looking like when they cough or sneeze.
Same thing for running. Let's see how you're running. And
running.
How that's...
Running and leakage should never happen. And there's so many things that we can do to help. And that actually, I have treated many runners and never even assessed their pelvic floor. We've actually looked more at their feet than anything, because if they're leaking and they're running, we want to look at their form and see what their foot is doing, because our foot actually affects our pelvic floor. So
that is fascinating for me.
Okay, say more.
How it's all connected.
Yeah,
fascinated
it is all connected.
now.
Yeah. So I've even treated virtually too for runners who are leaking or CrossFitters who have leakage, but our foot has to move and it has to have stability and flexibility. So if we are running and our foot is really stiff, if we've got like plantar fasciitis or like our toes are gripping quite a bit to stabilize when we're running, and that also depends on the surface we run on or the footwear we wear. So I usually talk to my patients about like foot mobility. I call it toe yoga. And so we want to make sure we have good mobility between our toes and our ankle can move, which is called pronation and supination, or like flat foot in a high arch position. But we want control in those two positions when we are walking or running. So we'll work on strength and stability in the foot, and it transfers.
To control. That's fascinating.
So lots of control. And then we work on the hip too.
So if you are peeing your pants on a run, you actually need to get your feet checked out.
100%. So not every pelvic floor therapist is going to think outside the pelvis. So we want to make sure like we also educate like our patients. If you're referring patients like who are leaking, like, and they are running and they are very active and they're athletic, you want to have a good therapist who's going to look at them head to toe.
That's great.
Because it's a whole system that influences the bladder. Yeah.
It all connects.
Yeah.
So I think, we're talking about urinary incontinence right now, and that is so important. And I think it is more common. And I think that women feel like, oh, well, that's just what happens. I get older after you have a baby. After you have babies. And I think the messaging is out there, right? Like, how often do you see a Depends commercial? It's so common.
And models
it's like
have gotten younger and younger.
Yeah. Well, are we getting older, Megan?
Oh no,
they're younger. We're just getting older. Yeah. But that's it's so advertised. Therefore, like, oh, well, that's what you do. You go buy a diaper. And you're telling us, Haley, that that's not the way it needs to be.
No, and it shouldn't be acceptable. Like we shouldn't be saying, welcome to motherhood. Like this is what happens when you have kids. But to be honest, like people without any kids are having leakage too. Like our gymnasts and like athletes in high school and middle school.
So why does that happen?
There's tension in their pelvis, or their feet or hips aren't moving well. So, or their personality type, they're high strung, they're hypervigilant, they're like type A personality. So we're tense. And if we're tense all the time, our muscles are going to be tense, and we need flexibility. It needs to be adaptable to what we do in life. So this is where we work on the nervous system and like regulating your nervous system and being flexible with that. So
things like breathing. And yoga and meditation, that can all be a part of this as well.
Yes.
Because we stored the tension in our bodies. I've done yoga. I enjoy it. And in most classes, when we do that frog position, that hip opener, the instructor will usually talk about like how we store the emotions in our hips and what have you. Do you feel that way? Is that a real thing?
So it is a real thing, but I think the message has gotten mixed with it. And there's actually research that shows it's not true emotion, but it's how the brain remembers like the event of what caused that tension or that restriction or the trauma that was there. So kind of, and in a way, and there's like a book called The Body Keeps the Score. And I talk to my patients about this, and I see it every day that I work on somebody, and there is emotion that is in our body parts. So when we work on it, whether that's stretching or just bringing awareness to that area, we can have an emotional response to that. And the pelvic floor and the pelvis is very vulnerable and very emotional. I mean, we have, as women, we're so like hyper fixated, especially if we have issues going on like leakage or prolapse and pressure. Like it's just part of us, and it defines us as a woman and a female. So
you and I were talking right before we started recording about fascial scraping, and that's something that I've started incorporating as a marathon runner into my wellness plan, what have you, in addition to massage. I mean, I've done a little bit of everything. Let's be honest. I've been an athlete all my life, and I'm always looking for like what's going to help me sustain my running life as I'm now in my mid 40s. So, massage and cupping and dry needling and all the things. But the fascia scraping has what you just described has done that for me. So the very first time I had my fascia scraped, and if you're like, what is she talking about? So your fascia, I'll have you. What is our fascia?
Fascia is around everything in our body. So it's all connected head to toe. It like encompasses every organ. It goes to the bones and muscles, and it conducts electricity and sends signals down and communicates with the brain. It's a whole organ in itself. So it's pretty extensive. Yeah.
Responds to water intake. You can get dehydrated.
And emotions too.
Yeah. And so if you've ever eaten ribs, little baby back ribs, it's that kind of white sinewy stuff on the back of the ribs. That's your fascia. So the very first time I went to have this myofascial scraping, I started crying. I mean, had this very uncontrollable, I was like, what in the world is going on right now? I could not explain it. It was very strange. Mm-hmm. And lo and behold, that's like a very common thing. Like, oh, everybody does that the first time. It's like, what is happening to me? What does this mean? What's wrong with me? What? Yeah. But it was a good thing. Yeah. I mean, I interpreted that as like, this all needed to come out of me. Mm-hmm. Whatever I was storing emotionally or whatever, the stress or what have you, but we got this stuff out. Yeah. And that is good.
It is.
I didn't want all that in me. Yeah. So yeah.
That's awesome. You went through that. It's surprising and weird for people who experience it randomly. The first time I experienced that, like treating a patient, she was coming to me for pain with sex, and she had gotten a divorce recently, and she wanted to make sure that she wasn't going to have pain with her next partner when she started dating again. And I was working on her calf, and she was a runner as well, and so I was working on her calf, and I got my dry needles out and I needled her calf, and I'm very like slow and intentional with it. I was like, I'm sure it didn't cause that much pain, but she like sat straight up and started bawling.
Wow.
And I was like, I'm so sorry. She's like, I'm sorry, it's not you, it's me. Like, I feel the same thing I felt when I found out my husband was cheating on me. I had sustained a calf injury to this calf like the day before it happened. So this is where the body keeps score kind of explains, like, as those chemicals that are flowing through your bloodstream and tissue injury happens, as that tissue heals, it lays down those chemicals. I'm not sure which is completely true, but I think that as you open up the fascial layers and work on adhesions, those chemicals recirculate and your brain reprocesses this at the same ratio that emotion was. Like, that's in it, you re-experience whatever trauma or emotion you had.
I believe it.
Yeah, it was wild.
I believe it.
That's fascinating.
Yeah, it was crazy.
All right, well, let's get back to the leakage. Yeah, I mean, you've already taught us so much, Haley. Incredible. Like the feet and the legs and the posture and the hips, it all can come back to that pelvic floor. So with urinary leakage, just from an OB-GYN standpoint, stress urinary leakage, we always like to categorize, right? And keep things nice and orderly and put things in a little box. So the stress urinary leakage is I'm guessing probably the main type of urinary incontinence that you're going to be treating. And so that's the cough, the sneeze, the laugh. And that, would you say, is that the most treatable when it comes to pelvic floor PT?
I think so. Okay. However, if we have like issues like pelvic organ prolapse playing a part in that, we like collaborate with gynecology or uro-gyn to work on getting some support there. Or like estrogen. Like if estrogen is low in that tissue health is really important to help control like our structures, like the contractile force, the pressure management. And I find that especially as women get into menopause, we have more like urge incontinence or stress incontinence because our tissue isn't as healthy and like flexible and like moist, I guess, as it should be.
Right.
And so when we support our bodies with that or a version that's similar to estrogen, it can be really helpful.
Absolutely. So so the stress urinary incontinence, and then the urge is that I gotta go, I can't hold it, it's coming out. And then we have other types, neurogenic, and that could be kind of from a nerve injury where the nerve innervation to the bladder is disrupted and the bladder's not getting the right signals. But yeah, let's transition and talk really about midlife. I mean, that's where Mary Kathryn and I are living these days, and a lot of our listeners are as well. And the role of estrogen in the pelvic floor. So say more about that.
Okay, so as a pelvic floor therapist, doing a lot of hands-on manual therapy, I've kind of learned what tissue health should feel like internally and externally. And as my patients age and they like see declines in estrogen or their hormones are just kind of out of whack, their tissue changes alongside it. And so like an internal exam, if we're working on incontinence, I usually do like urethral mobility alongside pelvic floor muscle mobility, and I can tell a huge difference when they are low on estrogen because that tissue is gritty, it's like rubbery and not as mobile. There's not as much blood flow to the area. And you usually start off with like, hey, let's start with some tissue moisturization. Let's try this sample here. And then if we need something a little bit more, we'll send you to your OB or gynecologist to get some either DHEA if they're a sensitive person or estrogen. And I find that like some of my patients who are more sensitive to chemicals do better with DHEA topically or suppositories. I don't know what your experience is or what you like to recommend.
Definitely vaginal estradiol. And thankfully, this year, 2026, the FDA, as a result of major lobbying by world-renowned gynecologists, specifically Dr. Rachel Rubin, due to her efforts, the black box warning has been removed from vaginal estradiol. And that's wonderful news because vaginal estradiol is safe for everybody, truly. It is not systemically absorbed. It is not going to raise, what that means is it's not going to raise your blood levels of estrogen. You can be a breast cancer survivor and it's still okay to use vaginal estradiol. Of course, discuss with your doctor. Please, please, please. Every person is an individual case, so please discuss with your oncologist, with your GYN. But if you are postmenopausal, perimenopausal even, and are experiencing things that Haley's describing with vaginal dryness, leakage of urine, pain with intercourse, this is due to a condition called genitourinary syndrome of menopause, or GSM, and the best therapy is using vaginal estrogen. Haley mentioned DHEA, which is a precursor to estrogen, and after application will convert to the active form of estrogen, which is a great tool as well. But it can be life-changing, as you're describing. So estrogen, the vulva, the vagina, the urethra, everything is just full of these estrogen receptors. And we're learning that there's estrogen receptors in muscle, in our capsules, in our shoulder, in tendons, like in our hamstrings. So again, it's all connected, isn't it, Haley?
Yeah, it's pretty wild. But it makes a huge difference when they're on that, and it's like game changing for pelvic floor therapy because when they're supported in that department, their recovery and rehab is so much quicker.
I bet. Yeah.
Because things are just working more effectively.
Yeah, there's better blood flow. Like they do well with manual therapy and their exercises. I mean, like it's protective. Estrogen is very protective, and we really do need support there.
Yeah. Brings life back to the tissues.
It really does.
Increases that pliability, that elasticity. Like you said, it just brings more blood flow. And without it, the tissues can just become paper thin, fragile. We call it vaginal atrophy. Just so delicate and can easily, be damaged even just with wiping after urination or with intercourse, or it just can be very uncomfortable. The urethra has a sphincter, so that is rich with estrogen receptors. Because it's a smooth muscle. And so it responds. It needs estrogen in order to contract to keep bacteria out of the bladder. So this is why we see UTIs, urinary tract infections, dramatically increase as we age. It's due to lack of estrogen.
Yep.
Fascinating.
I know.
So let's talk about pregnant moms? Yeah. What would be helpful for them to come to you?
So I say, I love, this is my like favorite thing to treat is like the women who are pregnant, because they start to change their anatomy and their posture changes so quickly, and the relaxin hormone helps like make things a little bit more stretchy, and then then with that comes like our muscles tense to help stabilize, and we have all these aches and pains. And then working with the uterus and that, like making sure there's not so much tension there to help baby find the right position when it comes time to have the baby.
Yeah.
But in pregnancy, if they're not high risk, we usually recommend them starting in, I guess, I usually say come early, because there's so much we can do and educate on even before like doing anything internal if needed. And sometimes in pregnancy, I've like treated people and not had to do any internal assessments or treatments. And we've worked externally, like doing massage on their pelvis or their ligaments of the uterus and their obliques and that kind of stuff, but exercise. But anyone who wants an easier labor, an easier recovery postpartum, go to pelvic floor therapy. It's not just going to be about your pelvic floor, but it's going to be whole body treatment. But yeah, research is showing that like pelvic floor therapy, doing rehab and exercise, strength training is so helpful for the baby, but also for mom for a lot of reasons. And I'm sure you know, like exercise is really helpful for mental health.
Yes.
So if we can work on that in pregnancy, it'll make them, you know, tolerate the bigger changes that happen postpartum. So
that's great. Yeah.
So sooner is better in pregnancy.
Yes.
And then what about postpartum?
Postpartum. So I'm a little bit different. I think that you can treat as soon as day one. I've seen moms like right after delivery, because we just had a major like a change in our body, and sometimes the pelvis is a little bit out of alignment, and so we'll do some gentle corrective exercises to help bring that pelvis back into alignment, close the pelvic outlet, and then we'll do diaphragmatic breathing. The most common complaint for postpartum women is the neck and shoulder tension from staring down at baby and their breasts to breastfeed. So I do a lot of manual therapy on their head, neck, and shoulders. We do like rib cage mobility, stretching, and then go over education, like how to get in and out of bed, how to lift their baby, how to engage the core so they're not straining and hurting themselves, and protecting their pelvic floor so that it can heal well.
I love that.
Yeah.
I remember my neck and back and shoulders
because you're hunching so much.
Yes.
You know? And then even carrying the baby or carrying the car seat.
All this stuff. Yeah, you're feeding and then you're burping. Everything's like on one side. And I actually had 2 back surgeries in my 20s. I herniated L4, L5. I was a pole vaulter in college and heptathlon. And anyway, so I have back issues. I did fairly well in pregnancy with my back, but it was postpartum. It was all the bending and the lifting in and out of the crib and the car seat and the loading and all of that. That's when I had the most issue, was postpartum.
Yep. I will tell my patients that if they've had previous injuries before pregnancy can accentuate those aches and pains, and then postpartum, that's a huge change, going from a pregnant belly to mush, basically. Like there's no support, no structure there, and your back is taking over because your core is offline and stretched out. So it's not an easy transition at all.
Not at all. But you're saying even day one, there's some things that can be done to help after you have the baby. Yeah,
and even for moms who, like people who undergo C-sections, I had an emergency C-section, and I got to experience both sides of it, vaginal and an emergency C-section. And we're trying, like PTs and OTs are trying to advocate for more physical therapy or occupational therapy in the hospital, because we just cut a woman open to get a baby out. We took out her core, so she can she can't stand up straight or lift her baby, or she shouldn't, but she has to because she's a mother now. So we're trying to get more rehab right away for patients who have had C-sections.
Even in the hospital?
In the hospital.
Wow, that'd be amazing.
It would be amazing. We'd have better outcomes.
For sure.
Yeah.
What do you want to tell OB-GYNs? What do you want them to know about pelvic floor therapy?
I think that we can do a lot more than is taught. And I think a lot of OBs and even urologists don't know what pelvic floor therapy is still, and it's really unfortunate because I work alongside several urologists now, and they're like, I don't know what to do with the things that people say they feel, like the feely things. Like they can operate and prescribe and all this stuff, but they're like, I don't know what to do when they feel this weird sensation. And I'm like, I got you. Like these are all the things that we work on. But like I just say all the weird and annoying things that you have no clue what to do, please send them out. Bowel, bladder, sex stuff and menstrual health is big because there's a whole body and several, like we've got all the systems that are connected and we can look at every single one of them and treat them.
Absolutely.
So, yeah.
Let's talk about prolapse.
Yeah.
Tell us what is that? It's a scary thing. You're about
so
to tell us something kind of scary, but tell us what prolapse is.
Oh my goodness. This is a big topic for both gynecology and PT. Pelvic organ prolapse is like the descent of your organs within your abdominal or pelvic cavity. Usually in physical therapy, we either say the anterior vaginal wall or posterior vaginal wall laxity. So we're not like scaring the crap out of people because it is scary. And if you feel anything heavy or protruding down there and bulging, you freak out.
Yeah.
Like, yeah.
Oh, I know.
As you should. Yeah. I would think you should.
They come find me.
Oh my gosh. Yeah. And I think I experienced this after my first birth, and I was like, oh my gosh, now it's my turn to experience this. But a lot of the times, like we'll refer out, or if we've been trained in pessary fitting, we'll send out to get fitted for a good pessary.
Okay, what's a pessary?
Pessaries are like, I call them splints.
Yeah.
They're like internal splints and devices that help support the pelvic organs. I tell my patients, this is like when you build a house, we're laying the foundation and the frame. And then with pelvic floor therapy, we're putting on the walls and the interior and the roof so that when we take the pessary out, we are hopeful that you no longer need it. And we have the structure around it to support the pelvic organs. So if we do it right, and this is where like postpartum, I highly recommend doing a pessary postpartum if they have like risk, if they're hypermobile, like those patients who just have extra stretchy tissue or they're a little bit older and have had multiple pregnancies and deliveries, like get a pessary first and our recovery is going to be so much easier. Okay. Pessaries come in all sorts of shapes and sizes. They're kind of fun. Yeah. I think of it as an art, and I haven't taken the training. I just know about all of them because I think it's cool. Yeah. But fitting is interesting because you have to take all these measurements of your pelvis, the opening, and take into account like there's muscle tears or like tissue sensitivity. And I mean, you can tell us more about that too.
Yes. So they are fascinating. There are many different shapes and sizes. There's a cube form. There's one called a Gellhorn that kind of looks like a knob with a circular disc under it. There are rings. There are all different varieties. And like you said, I think scaffolding is a beautiful description. They go into the vagina and they stay there, and they're designed to support whatever it is that's coming down. And so when I do an exam assessing for prolapse with a speculum in my office, I will, and then I have the conversation with the patient to describe what I'm seeing. I will tell them, similar to what you just described, think of your vagina as having a ceiling, a back wall, and a floor. It's a three-dimensional space. And so what's on the other side of that ceiling is there's fascia. When we started this conversation about fascia, fascia's everywhere. But there's mucosa, there's fascia, there's a layer of supportive tissue, and on the other side of that is the bladder. So that's the ceiling. And when prolapse happens, think of it as those ceiling tiles are starting to cave in. And it can happen on various degrees. So, and as you can imagine, if that bladder is no longer anatomically in the right position, it can't contract fully. So this is where you get incomplete emptying of your bladder. You feel like you have to pee, you go pee, and then nothing comes out, hardly, or you feel full. You don't feel that sense of like, I fully emptied. So, and then if you have this kind of stagnation of urine that you're not completely emptying, you have a higher risk of having infections. So it's a problem. the back wall is where the cervix and uterus is, if the woman has one, or if she's had a hysterectomy, it can just be what we call the vaginal cuff. So kind of like a cul-de-sac. It's a ending of just vaginal tissue there, but that can drop down as well. So it's important when we are examining as gynecologists to know what's dropping. What am I looking at, right? Because it can't all look the same. And so there's different ways, different maneuvers you can have the woman do to fully assess what is prolapsing. And then the floor is on the other side of the supportive tissue. There is the rectum. And so weakening of the posterior or the floor tiles, so to speak, weakening there can cause a ballooning of the rectum to kind of come up and into the vagina where it really shouldn't be. And then that can cause issues having a bowel movement or fully emptying the rectum. So the rectum gets full of poop, and then sometimes in really severe situations, because there's so much ballooning, we call that erectocele, where that rectum is actually ballooned up into the vagina, they have to do maneuvers we call splinting, where digitally they have to place fingers in the vagina to push down to actually get the rectum to evacuate. So, and guess what? Nobody wants to talk about these things, right? Mm-hmm. They come into my office, and Mary Kathryn, you are so good at normalizing like hard conversations like this, right? Like I know you've taught me how to assess for postpartum depression or even postpartum suicidal ideation or hallucinations. Like, hey, some people hear voices and is that happening? right? So I've tried to use that same method. Like sometimes women will have to place fingers in their vagina to help get the poop out. Does that ever happen to you? Of course, if I'm seeing what I'm seeing, right? I'm not asking everybody that, but if I do the exam and I'm like, wow, she's got some prolapse going here.
Yeah.
Normalizing that because they're not just going to come out and tell anybody that they're having to do the things they're having to do to empty the bladder, to empty the rectum. Mm-hmm. So that is prolapse in a nutshell, the ceiling, the back wall, and the floor.
Yeah. I would say one of the most challenging aspects of treating prolapse is like the patient's mentality behind it. Their mental health is severely affected because they have this constant awareness of this tissue down here. It's a pressure that is always there when there's problems, when they're symptomatic. And not everybody with prolapse is symptomatic, but usually the like lower grades, the less intense ones, or the immediate postpartums, they experience more symptoms, and it's just like your body's not broken. And I try to reassure them like this can be a normal part of what's happened with your birth experience or with your history of what's going on. It's going to be okay. You're in the right place. We're going to find the right support for you, and just trying to work on their nervous system, the calming, the grounding, that kind of stuff, and working on everything around it. But people get hyper fixated on it, and they just want to protect it and make sure they're not going to make it worse. So that's probably the hardest part, is the mentality behind it.
I would imagine, and just feeling shame around it too, because just like the urinary leakage can happen, the fecal incontinence can happen as well, and that's something that they really don't want anybody else to know. But can pelvic floor therapy help with fecal incontinence as well?
These are the questions that I get to ask. Like, I'll ask the dirty questions, like the gross, like the TMI stuff. And I love doing that. I like talking about the uncomfortable stuff because nobody else is talking about it. But I'll ask like, hey, when you wipe, is it like a marker? Is it constantly like going and you're wiping and it just doesn't stop? Or do you feel like you have to put pressure on the perineum to have a complete bowel movement or any of the weird stuff? Or another common one is like, are you able to control your gas? Like when you have flatulence, can you control it? Or do you have to push it out? Or does it come out randomly when you don't want it? So that kind of, those questions are really important. The fun ones.
And all of these things can be improved.
And they're all important. They're all parts important of your health.
We don't have to live like this, which is good.
Huge.
So now, I know some patients will need surgery. Right? So I think it's important just to say that while physical therapy, pelvic floor in particular, pelvic floor therapy is so necessary and I think underutilized. I know in my practice, I'm trying to refer as much as I possibly can. There are some situations where surgery will be necessary, but
probably it can go together. It
yes,
sounds like
it does
you
go
can
together.
prepare for surgery and then
Speak
after
to
surgery.
that.
Yeah,
Tell us more about
that. I've seen treated patients who want to prevent surgery.
Yes.
So we'll go through, manual therapy and exercise and that kind of stuff. It will reduce the prolapse significantly, but there are some times where like their genetics, like their lifestyle, it's not long lasting and they'll get frustrated. I'm like, okay, I think we should consider that surgery, and then we'll do rehab afterwards to address any symptoms of the surgery. And then I'll have patients who will come after surgery for prolapse, and we're dealing with like spasms and like scar tissue, that kind of stuff, and then returning to sexual activity. So we're just getting them back to baseline and improving their quality of life. So and when we assess the pelvic floor, we screen for prolapse, and we'll get them in standing when they are more symptomatic. And if those organs are coming down and out like an inch or more, we're like, let's get you set up with somebody to get a consult and figure out a plan from here.
Good.
Yeah.
And
really good.
and I refer to urogynecologists
Yes.
widely. We've got some really good ones here in town and that are so talented. Dr. Miller, tell us, as we wrap up, what should all women be doing to protect their pelvic floor, to set their pelvic floor up for success so that our future selves thank us?
Okay, taking care of ourselves. So that's like the basics. So adequate hydration with minerals and electrolytes, so not overhydrating. Making sure we're pooping every day, taking care of that part of it. Nutrition, I mean, literally all the basics of life. And then mental health, like making sure you're taking care of your mental health, working on stress management and tolerance. I mean, and then breathing is a big one. So if we can take deep breaths and expand our rib cage 360 degrees, like we're opening up an umbrella, we breathe into our back and armpits more than the front and chest and neck, I think our bodies will be more relaxed, and then everything else will kind of follow along. So those are essentials. Yeah.
Taking a big deep breath right now.
I know.
I love that.
Yeah.
Good. So drink more water, eat more fiber.
Yep. Move more too.
Move your body.
Yeah, move your body. Your pelvis needs it.
That's awesome.
Yes.
That's awesome. Well, what are your parting words?
Ooh. I would say that you are not broken and you are strong and capable. I feel like a lot of women struggle with that, and our bodies are amazing and they can heal itself. So let it do its job.
Yeah, that's great. And there's help out there.
Yes, and there's help.
There's help. Thank you so much for being with us today. Thank you for taking time to come. I think this was so helpful. We both learned a lot, and I know our listeners are going to learn so much. So share this with a friend, share this with a sister, somebody who you know this will be helpful for. We're so glad you joined us today. We'll see you next time. Thank you for joining us on a journey to whole woman health. If this episode encouraged you, share it with a friend, leave a review, or subscribe so you don't miss future conversations. Remember, your questions matter, your health matters, and wholeness is a journey. Until next time.
Now for the legal language. The information shared in this podcast is for educational purposes only and is not intended as medical or mental health advice. Listening to this podcast does not establish a doctor-patient or therapist-client relationship. Always consult your own qualified healthcare provider regarding any medical concerns.